so we wouldn't contemplate skin excision, and maybe 6 to 12 months following the surgery, if we're in that delightful position of having a comfortable lid with surplus skin. I don't think we'll be there, but that's always a backup plan, a nice backup plan to have for her. So what we've just finished is a rather complicated but anatomically, logically correct type of facelift on this woman whose main concern was the laxity of the labiomandibular fold. You can see this here and there. Laxity of the jawline, and then she had this overriding medical condition where she had persistent discomfort of the left eye because she'd had complicated upper and lower lid surgery with over resection of the upper lid skin, scar contracture of the left lower lid, and even though she'd had repairs with a mucosal graft to correct the contracture and with a tarsal strip repeated twice, she still had discomfort. And she shows here how she exaggerates the discomfort by simply slight tension on the cheek down, but relief of discomfort with a slight upward positioning, which is quite interesting. And there's no doubt that her degree of mobility here is way beyond you'd expect for someone of her years. And I think that's largely due to the fact that she lost so much weight. So what we did is a composite facelift, releasing the ligament, the zygomatic ligaments way medially so we could get enough vertical lift to improve the downturned corner of the mouth. And then we replaced the zygomatic ligament further medially with a figure of 8 3/0 suture, which is effectively a new zygomatic ligament. And that brought up a lot of cheek skin up into the pre-zygomatic area, which we then managed by tightening the orbicularis retaining ligament here, which then you could see there was less tone or less traction on the lower lid. There was no traction. In fact, there was redundant skin there. And then the malar mound was then redraped laterally to correct the surplus here. So that's the benefit of putting sutures where the ligaments are rather than simply tightening around the periphery, because then you can change the vectors. You can have a vertical lift here, transverse, and even a downturn further lateral. And then for the labiomandibular fold, we did the usual release of the lower key masseteric ligament, the section right up to there, then went in through the middle premasseter space and saw the buccal fat, drew the buccal fat out of its descent here in the lower part of the buccal space, and then put a suture to the wall of the buccal space, not the posterior wall where the buccinator is, but the anterior part here. And immediately you saw that on the video. This took the laxity out of this area, which is very difficult to correct otherwise. You can see this amount of laxity just here. So I'm very happy the way we've corrected that, and that correcting the jowl is achieved with tightening the lower premasseter space. I was most surprised with the amount of redundant skin laxity of her neck, because we didn't do a skin undermining. This was purely by tightening the platysma, this posterior, simplified posterior platysma suspension to Loray's fascia, which is just at the lower part of the tragus, and then a secondary tightening to the platysma auricular ligament, which is that fibrous structure on sternomastoid. And that yielded more than 2 centimetres of extra skin. So her neck improvement is really a bonus. Then we had to be so careful with the temporal hooding because the brow had descended off the superior orbital rim, and whenever the brow loses its projection on the bone, it drops down into the upper lid. So you can see the crowding of the upper lid. But unfortunately, because of the previous upper lid surgery done 12 years ago, if we brought the brow back to its correct position, the over-resected upper lid would have meant that she had true logophthalmos. So what we did is put some fat into the excessive hollowing, which is possibly due to the previous surgery, but maybe just part of aging, and that brought some of the hollowed upper lid, which causes the skin to hollow in, release some skin so that the upper lid has a little bit more movement. And then we did effectively a type of subcutaneous temporal lift to bring the laxity up and around so that we could bring the tail of the brow up without interfering with the lid closure. So that superficial temporal lift is the name, or a galeopexy it's called, but really it's a subcutaneous temporal lift, which is really a characteristic of the skin of the temple, which normally when you do a composite flap, tightening the deep layer adequately tightens the laxity of the skin, as you see on the cheek. But on the temple that doesn't work the same, and there's still too much skin laxity. And then we finished up with a revision of the tarsal strip that she'd had before and did a drill hole canthopexy, still leaving the tarsal strip in place, but redirecting the force so that there was a better posterior vector of that inside the orbit through the benefit of the drill hole canthopexy. And now it all depends on the swelling post-operatively, but I don't think she'll have all that much swelling because we give the patients prednisolone, which dramatically improves the amount of swelling. This is in addition to dexamethasone intraoperatively. Thank you very much for your attention. I hope that these videos have stimulated you in a way to apply some of the principles and even start off with the surgery. For example, if you haven't done this type of surgery previously, I would suggest you start off with the lower premasseter space because it's so safe and so effective, better than any of the traditional alternatives. And then once you have confidence in that space, move up to the middle space and then eventually into the buccal space if you feel inclined. Prezygomatic space is more difficult, but it's not more dangerous, it's more difficult to know where you are. Also, the tarsal fixation technique, for example, this last patient, had she had tarsal fixation, wouldn't have had this problem of over-resection, and that's led to so much difficulty for her. And I'd just like to thank the producers of this video series, particularly Elaine, who's come all the way from St. Louis to Melbourne, Australia to film this over 3 days, and to Terry Tiong, my assistant, without whom this could not be possible. And then 3 anaesthetists we've had, a different one each day, which have given outstanding anaesthesia. You would have seen the blood pressure is always controlled, so there's not been a difficulty with extra bleeding. I wish you all good luck with your surgery. Thank you. Here is our patient shown before the surgery. You remember so much of the planning for the surgery evolved around her eyelids because we needed to protect against lagophthalmos because she had undergone overdone upper and lower lid surgery in the past, and she had a middle lamellar graft of the lower lid as well as a tarsal strip procedure. Here you can see that the general feeling of dragging down of the cheek does not occur in the post-op view. There is a buffer between the cheek and the lid, which is the orbicularis retaining suture in particular, which separates the malar mound area from the lid proper, a very important aspect. You'd be interested to know how she fared with the improvement of her symptoms. Well, I'm pleased to report that she says most of the time I'm not aware of the lids, and in fact the dragging down sensation has completely gone. So this was very satisfying. When you see her close up, without her hands on the cheek, you can see the importance of the hydroxyapatite augmentation over the zygoma and the maxilla. The general look of her cheek is so much improved. Also, you can see that the superficial temporal lift has raised the outer brow and opened the eye a little bit, but it has avoided having any detrimental effect on the upper lid position. When you look at her recovery, it's significant that the bruising is more on the area of the facelift where the work was performed laterally, but the medial cheek has almost no bruising, and the bruising around settles pretty quickly, really. The improvement of the jawline front on is also quite significant when you can see that in the 2 months post-operative view. Her other concern was the jawline, and you can see straight off that this is dramatically improved straight after the surgery, and then at the 2 weeks mark the bruising is already gone because it was rather superficial bruising, and she has a nice appearance of the jawline, which you can see better in the oblique view. You can see the jowl hanging down, and straight off the improvement of the jawline and the submental region from the posterior platysma suspension sutures, and the hydroxyapatite placed in the pre-jowl region, which does not contribute to bruising and minimally contributes to any swelling. So although she does not look dramatically different, she does look fresher and healthier, and she is symptomatically relieved of her eyelid problem.